So good evening to all of you. This is a class that Sanket has been asking me to do for some time and I've been postponing. Because I used to do this in Manipal, where we used to have something like interactive quiz kind of session. And we used to put up x-rays. Because I found that this is one area that's completely neglected. In undergraduation, you're not taught how to read x-rays. And in post-graduation, it's assumed that you already know how to read x-rays. So in between this gap, I think people don't really concentrate on x-ray reading. And it's a very important skill because this is something that you deal with every day. And unless you know how to read an x-ray, it's going to be difficult for you to work your way through medicine. Because though we may say CT scans are available, you can't do a CT every day on everybody. So I think chest x-rays reading skills have to be definitely tuned in. And what I find is that we will do only chest x-rays in this session. Well, initially I told Sanketa I'll do imaging, but I don't think it's possible. I can't even do more than this. I think there are about 90 plus x-rays there. So I can't go faster than that. And I don't think we'll be able to complete anything if we go faster than this. So let's start, and I will start with a few basic slides. And then, like Sanket said, it's an interactive session. So you should be on the chat box and I should be reading that. So let's start. Okay. Okay, right. So how do we read these images? It's a very essential skill, like what I said. It's good to have a method. It's good to have a method in the sense that you say chest x-ray, PA view, AP view, what is the rotation? Is it okay? Is there any problem with the exposure or penetration, etc.? It's good to see that and read it from above downwards. Okay, start from the top and then go to the bottom so that you know you have covered all the areas of the chest x-ray. And many times after a while, after a few years in medicine, then you know that you're kind of confident, and then you can look at an x-ray and then generally, give an opinion. But that comes when it's like Google, it's a pattern recognition, and it is it's gained by seeing more and more x-rays. What I would suggest is that people should commit on the x-rays and not wait for somebody else to give a diagnosis. Just commit on it. Whatever you think is right, you commit on it. Then only you learn where you've gone wrong and where you can correct yourself. So my advice is, like I tell for ECGs, if you want to read x-rays well, keep writing the reports every day. Okay, most of the time we ask for x-ray, PA view. AP view is done in people who are lying down, who can't be shifted, who are in the ICU, etc. So why are we doing this? For us to understand this, you must know that when you have an X-ray beam coming up, then you know the patient is standing in front of a cassette and he's like hugging the cassette, and the X-ray beam comes from behind and goes to the front of the patient. Now, the idea is that shadows are clear when they are further away from the light source. So if you can do this yourself, if you have a paper and you have a pen and a torch. Nowadays, nobody has a torch. It's only a mobile phone. But if you keep the pen, and move towards the paper and keep a light source like that, as you go closer to the paper, then the image of the pen, the shadow of the pen, not the image, the shadow of the pen becomes clearer. So whatever you want to see clearly, you put it away from your beam. In this case, we want to see the heart. So that is why we are doing a PA view. You're putting the heart further away from us, and that's why we are doing that. And you can recognize PA view by looking at the clavicles. They are in, whereas in the AP view, they are up like that. And the scapular shadow moved away here can be inside here. And these are subtle things that you can make out from an AP view or a PA view. But generally, we have to do a PA view because we want to image the heart. That is the reason why we are doing a PA view. And of course, we want to see the lungs, but the lungs are not going to cast any shadow. It's only the ribs that are going to cast a shadow. So I want you to comment on these three X-rays on your chat box, please. I want you to comment on these three X-rays. What do you think of them? Let's call them A, B, and C. What the first X-rays? Let's call this A, B, and C. What do you think is right or wrong with them? Okay. Somebody said underexposed, normal, overexposed. Okay. It's the exposure that is a problem, correct? What about the penetration? What about the penetration? How much should be the normal penetration when you see an X-ray? How much should be the... Okay, somebody says C is right. Do you agree that C is right? Vertebra 4. Okay, it's not vertebra, spine, isn't it? Spine 4. You should be able to see only 4 spines here, and behind the heart, you should not be able to see the vertebra. In this X-ray, for example, you're seeing right through the vertebra behind the heart also. That means the thoracic vertebra. That means it's an over-penetrated X-ray. You're likely to miss all the white shadows. Of course, this X-ray is a question of exposure. It's like, you know, completely black, and you're not going to see anything on that. So remember that unless you get a correct exposure, correct penetration, where you should see probably this is a better X-ray because you can barely see the fourth spine there. And then beyond that, you're not able to delineate the vertebra. So this is probably the better one. Whereas here again, it's over penetrated. So before you comment on anything, remember that you have to check these three things: the exposure, the rotation, and the penetration. I will show you the rotation now. Okay. Okay, right. Okay. One more X-ray is here. Which is the better X-ray I have asked? Okay, between these two. I'm sorry, something is happening to this. Yeah. Which is the better X-ray of these two? This one or this one? This is again over penetrated. You can see the spine here. So that is why this is not a good one. And this is probably a better one because you're seeing 1, 2, 3, 4, and then beyond that, nothing much. And this person has taken a good breath. You're able to see up to the 7th, 8th rib here. This person, this is also not so bad, but many times you get a person with a bad, breathing pattern, or they do not take a good breath. Then the diaphragm sits somewhere up there and you're losing out lung. Please remember that when you're doing a chest X-ray, you cannot see most of the lung. About 30% of the lung is behind the diaphragm here and is behind the heart here. Okay, and some ribs. Ribs are also covering some part. So remember that you're not seeing everything, and the mediastinum is never correctly imaged, never really seen. The structures are never really seen on an X-ray. So having missed out all that, the one thing, you can't change the position of the heart, you can't make it transparent. Only thing you can tell the patient is to take a very good breath so that the diaphragm really goes down and you get more and more of the lung that you want to image. So let's move on to the next one. Okay, that's about the rotation. Whenever you have a rotation, please remember that you should not comment on any midline structures because see this X-ray, for example, this must be an ICU X-ray where the leads are there, and you can see one clavicle here, one clavicle here. That is the spine. So you're looking at the distance between the spine and the clavicle. And obviously, this is very close and this is very distant. The trachea looks shifted to the right, but you can't comment at all because it's totally rotated X-ray. So any midline structure like the heart, like the trachea, cannot be commented upon if there is a rotation. So before you say something is shifted or not shifted, look for the rotation correctly. So these three are your basic parameters. And now let's go on to, this is probably the last X-ray that I'm going to talk about some general things. So you can see the normal chest X-ray, what all it images. So that's the lung there. And this is the heart here. And as you can see, the most common mistake made is that this shadow of the heart is interpreted as right ventricle. Remember, the ventricle is here. That is the ventricle, okay? That is the right ventricle. This is the right atrium. So the right atrium forms the right border of the heart and goes up as the SVC and down as the IVC. So remember that the right ventricle does not form any border of the heart. So don't go and comment on any right ventricular hypertrophy on an X-ray by looking at the enlargement of the heart. Okay. And then as you go up, this is the superior vena cava. Here, you know, the left border of the heart is the aorta, this pulmonary artery, the just peeping left atrial appendage, and that one. And then you have the left ventricle. And remember, the right ventricle ends here, so it doesn't form. The apex is always formed by the left ventricle. And then you have the lobes of the lung. But when you're reporting an X-ray, you're not going to call them as lobes. You're going to call them as zones, which again, I think I have a slide on that and I will show you. So let's go on. Okay. There are 3 densities on the chest X-ray, and all of us know that. One is the air density, the second is the fluid density, the third is the bone density. Air, we all know. Air is the lung. It's translucent, so nothing you can see. It doesn't cast a shadow on anything. Remember, the X-ray is a shadow. Bone, we all know. Bone is the ribs. Okay, those are the bones, the clavicle, scapulae, they all cast shadows. They are dense. So the bone shadow is dense. But there is an in-between density, what we call as the fluid density. So what all structures would come here in fluid density? Can you all type? What are the structures that will have fluid density? What is fluid? Which structures? No, normal structures in the chest X-ray which are of fluid density. I'm not asking effusion. Not effusion. Okay, the vessels, then stomach. Stomach doesn't come in the chest X-ray. Hopefully. Heart, okay. Right. It's a heart, it's a diaphragm, isn't it? The diaphragm, the heart, these are the structures, and the your vessels, these are the structures that are of fluid density. So these are the 3, the X-ray knows only 3 densities. It knows only 3 types of shadows. One is air, which is no shadow. One is the fluid density, where you have the diaphragm, the heart, and the vessels. And the last one is the bone density, which is calcium. So it is very white. So the bone is very white. The fluid density of the heart is not so white. It's in between. That's why it's called fluid density. Okay, so let's move on. Okay, I want you to... Okay, I want you to read this X-ray. Normal, abnormal, whatever it is. If you can make out any abnormalities, please read. Okay, just X-ray PA view. Any abnormalities? Normal. Normal. Okay. Hyperinflated. No, the fellow has the lady has taken a very good breath. We should congratulate her on that. That's not hyperinflated. Anything else? Anybody? Anything else? Any abnormality made out, or it's a normal X-ray? That's it. Nobody's answering anything more. Okay. So, like I told you, you must start from the top and come down. Okay. Of course, it's over penetrated. Okay, slightly rotated. Okay, all that is correct. Okay, bronchovascular markings are good. There's nothing wrong. Okay, then. Okay, let's start at the top. Okay, fine. So, right. So this is the first strip. Can you see the first strip here? Okay, this is the first strip here. What is this? Can you make out? What is that? That's a cervical rib, isn't it? That's why I said you must start from the top. Okay. What looks to you as a normal X-ray, please remember you start from the top. So one way of differentiating a cervical rib from the thoracic, the first rib, is the direction of the spinous processes which are attaching to the rib. As you can see, this will look up, whereas cervical will look down. So this is the cervical rib. You can make out a small one here. Okay, so don't miss that. When an X-ray looks near normal to you and somebody is asking you, is something wrong with this X-ray? Please remember there must be something wrong. And some mistakes that people often make is to call that a pneumothorax. That is not a pneumothorax. It's a breast shadow and the diaphragm. It looks equal on both sides. So don't go and overread an X-ray in any way. But don't miss a small cervical rib which is looking at you right at the top. So get into the habit of, kind of going in an order so that you don't miss small things. Why is this thing not moving? Yeah. So that's what we feel when we have missed a small thing on an X-ray. Right. Let's go to the actual quiz kind of thing. So let's look at this. Simple diagnosis. Diagnosis, please. Yeah. See. Has anybody replied to this?
Yes, ma'am. There are multiple reply.
Oh, really? I can't see. I'm
Just
wondering what is happening. Okay, right. Okay, maybe. Ah, yes. Okay. Overexposed. Pleural effusion. Tension pneumothorax. Effusion right. Left pneumothorax. How can we be so divided on our opinions? Okay, right. Right. Pleural effusion. Left pneumothorax. Mediastinal. This thing. Left side rib fracture. Where is that now? Okay, fine. Right. Okay, so you're calling this a pneumothorax. If this is a pneumothorax, what is this? First of all, how do we read an X-ray? What do we call this? We call this a homogeneous opacity, isn't it? If you want to call this something, okay, like I told you, please don't call this a pneumothorax because there is no edge of the collapsed lung here. And if that's a pneumothorax, do you mean to say there's a pleural effusion also on this side? Isn't it? So we can't call, both sides he's having some trouble and which are like opposites. That cannot happen, right? So this is not a pneumothorax. And remember, though we told everything must be ideally exposed, correctly penetrated, it never happens in real life. So you have to have some kind of, course correction in your mind so that, you kind of adjust for all these irregularities that happen, right? So let's look at it. So obviously, if there is a pneumothorax, you should have had a hedge of the collapsed lung here, which is not there. And you should not have had anything on this side. This poor lung, what did it do? If this is a pneumothorax, this one should have been all right, right? This one is not all right. So then this is not the abnormal thing. This is the abnormal side. If this is an abnormal side, then you look at what is the kind of opacity that you have. What is the kind of opacity you have? Homogeneous or non-homogeneous? What is this opacity? Homogeneous or not? Okay, homogeneous, correct. So it's a homogeneous opacity on the right side of the lung field, okay, in the upper, middle, and lower zones, all three zones, with the trachea looking very much to the right side. Of course, it's totally rotated. Of course, it's totally rotated, but that you would apply if everything else is normal and you can't understand what is happening. Then you would say, if you attribute this tracheal shift to the rotation, then you can't explain this shadow. You understand? Okay, part of the shadow, especially in the lower part, could be the heart. Could be because the heart is here. Okay, so some part of the heart must be here, so it's definitely pulled. So the heart is also pulled, the trachea is also pulled. Homogeneous opacity, right side. So the diagnosis is right-sided collapse. Correct? Okay. So please remember, before you commit on anything, just look at both sides of the lung before you say this is a pneumothorax or this is a collapse. Just go around, look at it, and then commit. Okay. Right. Let's go to the next one. What is that now? What is that? Yes. Right pleural effusion, right pleural effusion, effusion right, consolidation. One. Any more? So it's a homogeneous opacity on the right side of the chest involving the upper, middle, and lower zones. Correct? Okay, fine. Now, there are three causes of homogeneous opacities. What are they? They are a collapse, a pleural effusion, or a consolidation. Now, how do you differentiate these three? How do you differentiate these three? You look at the central mediastinal structures. So, look at the trachea. So, what happened to your trachea here? Central. So, what's the diagnosis? What's the diagnosis? Consolidation, isn't it? It's a consolidation. Okay, fine. So whenever you read, go in that order. Homogeneous opacity, right side of the chest. involving upper, middle, and lower zone. Okay. But the trachea is central. It's not a pleural effusion because it's not pushed to that side. It's not a collapse because it's not pulled to this side. That's why we have to call it. Okay. I don't see any push, doctor. Okay. And for this kind of an effusion, your tracheal shift would have been massive and your heart should have been lying, somewhere here. But nothing has happened. So that's why you have to think that this is probably a consolidation. If you have any doubts, then you could always do an ultrasound or a CT scan to go ahead and see whether there's a pneumonic effusion sitting there. That we cannot differentiate here. Now, what happened to the right diaphragm? What happened to the right diaphragm? Anyone? What's wrong with the right diaphragm here? Yeah? Anybody? Not visible. Yeah. Somebody asked query silhouette sign. It's not query, it is silhouette sign. Like I told you, the effusion and the diaphragm are similar densities. Both are water densities, fluid densities. When two shadows of the same density are in the same plane, then they merge with each other. That's why you're not seeing the diaphragm. So don't go and call it some diaphragmatic paralysis, diaphragm lost somewhere in translation. That doesn't happen. Okay, fine. So that's probably a consolidation. Okay, we always say probably because we are never very sure. What is this X-ray? This X-ray, please. Yep. Fusion. Okay, at last we agree on something, isn't it? We are not divided down the middle. Okay, fine. So there's a homogeneous opacity on the right side involving the upper, middle, and lower zones with the tracheal shift to the opposite side. The heart also is shifted to the opposite side. So that's why we are thinking that this is a pleural effusion. So all three densities I showed you, you differentiate by the position of the mediastinum, whether it's an effusion, consolidation, or a collapse. Okay, fine. What is that? What is that? Effusion, hydropneumo. Okay, go on. Effusion. Okay, right hydropneumothorax, left hydrothorax. Okay. Okay, left pleural effusion with meniscus sign. Okay, left side effusion. Again, when we read, we should always say homogeneous opacity occupying the left, mid, and lower zones, right? Okay, with, minimal shift of the trachea and the heart. Minimal shift. It's not a great shift. Okay, there's a mild shift there, right? And of course, you can see there is a small up here. What is this curve called? What is this? Ellis curve. Okay, Ellis S-shaped curve is there. So that's why we have to think that there is an effusion. But what's odd is that for this big an effusion, which is probably moderate, you don't have much of a tracheal shift or a mediastinal shift. So you should think that, oh, okay, there is an effusion. Is there a consolidation with an effusion? That we don't know. Okay, that we don't know. Or it could be just the effusion and it's not very shifted. It's not, of course, massive. It's somewhere around moderate. But because of this uptick here, okay, we should think that there is a fluid there. Now, those of you who called it a hydropneumothorax, okay, that line would have been one straight line, okay. The water in the bottle that you fill, if it's a half-filled bottle, it doesn't curve up any side of the bottle. It just gives a straight cut. So, and you should have seen the edge of the collapsed lung if it's a hydropneumothorax of this size, okay. So that's why, and you can see the bronchovascular markings here. You can see that, so it's not a collapsed lung. There is a mild shift of the trachea. We would vote for an effusion. Whatever is there or not there, there is definitely an effusion. Whether there's a consolidation associated, okay, fine, let's think over it. That's how we would go about this X-ray. Fine, what is that? That one. Mass lesion, okay? Right upper lobe collapse. Right upper lobe collapse. Everybody is saying collapse. Left inhomogeneous opacity. Right, middle lobe consolidation. Okay, fibrosis. Have we left out any pathology? That's what I'm trying to think. Okay, fine. Let's again describe it. Okay, how do we describe this? How do we describe this? Homogeneous opacity occupying the right upper and most probably only the upper zone, isn't it? So the first two ribs are upper zone, the 2 to 4 is mid zone, and below that is lower zone. Remember, the X-ray you always tell as a zone. Okay, fine. So somebody noticed that there's an air bronchogram, isn't it? There's an air bronchogram there. Can you make out? And the trachea has not shifted. Why are we calling it something else, saying that there's a collapse? Where is the trachea? Of course, this is the minor fissure. Correct. That looks a little pulled up. I agree with you, but it's a nice, correct, respecting lobar boundaries. This shadow is not crossing lobar boundaries. So it's sticking to a low. Okay, that is more in favor of a consolidation. And rarely you see such a beautiful air bronchogram. Air bronchogram is a sine qua non of consolidation, but it doesn't happen in everybody. It happens only in a few people that you see the air bronchogram, but once you see it, there's no differential. It's a consolidation. It's a lung which is consolidated around this thing. Okay. Okay, fine. Somebody is calling it all these things as no bronchivascular markings. It's a question of the exposure, doctor. So that's why I said, don't expect real life to be ideal. And don't call everything as a pneumothorax. If there is a pneumothorax, where is the edge of the collapsed lung? You're not seeing it there. And you got an obvious thing on the other side. So let's not call this a pneumothorax, this a pneumothorax, and that a consolidation, then he's not alive. So that's an air bronchogram. Okay. That's a very typical feature of a consolidation. It's a right upper lobe consolidation. Right. So let's go on to the next one. I want you to spot the difference between these two X-rays. Okay. Yeah. So what is the diagnosis for the X-ray A and X-ray B? X-ray A and X-ray B, what is the diagnosis? Pneumonia, homogeneous opacity. Go on. Anybody else? Consolidation versus effusion. Okay. You're giving me a choice. CP angle blunting. A is resolution of a pneumonia. Okay, fine. Yeah. Anybody else? What happened to B now? Right, lower lobe consolidation with effusion. Consolidation with effusion. Okay, fine. Right. Now let's look at this X-ray and this X-ray. Right? Okay. So you are getting a shadow in the right lower zone. Homogeneous shadow. Right? Homogeneous shadow involving the right lower zone. Correct? Okay, fine. And look at the heart. And look at the diaphragm. So this you are calling, most of you are agreeing, no? This is a consolidation. Okay, fine. So what is this? Where is this consolidation? Where is this consolidation? Which lobe of the lung is involved? Which lobe of the lung is involved? Lower, right, middle lobe. Okay, those of you are calling it middle. Why are you calling it middle? Because it is silhouetting the heart, isn't it? The heart border is not well seen. It's silhouetting the heart, two shadows at the same level, like I told you, in the same plane of the same density. So that is why this is a middle lobe consolidation and a well-seen diaphragm. A well-seen diaphragm. If it's a lower lobe consolidation, then you should have silhouetted the diaphragm. You're not silhouetting the diaphragm, okay? The diaphragm is decent, and that's a heart shadow. I don't think that's the lung shadow. And here you got something here. So this is probably a middle lobe consolidation. Okay, let's look at this one now. Now we look at this one. You can see the heart border. Can you? Yeah. You can't see the diaphragm, right? So it's silhouetting the diaphragm. It's not silhouetting the heart border. So it's not close to the heart. It's not in the middle lobe. It's probably lower lobe, okay? Because it's sitting on the diaphragm. All your lower lobe segments will sit on the diaphragm except the apical segment of the lower lobe. Everything else will sit on the diaphragm. So that's why you're not seeing the diaphragm. like the usual silhouette sign. So this is a good use of the silhouette sign where you can see the heart through the shadow. That means it's not in the plane of the heart. Okay. That's why it's probably not a middle lobe, whereas this is silhouetting the heart. So this you would call as a middle lobe. So this is the use of the silhouette sign by which we can look at. Of course, we can go clinical. Of course, the easier way of doing it is to do a clinical examination, auscultate the axilla, auscultate the back infrascapular areas. You should probably get your diagnosis more easier than this X-ray, right? Fine. So let's go to the next one. So this is what I was trying to tell you. Two shadows of the same density, the same plane will merge. If they are on different planes, they'll be seen through each other. That is the principle of the silhouette sign. Okay, so let's go to the next X-ray. Okay, so let's look at that. Okay, there are two more X-rays here. So we should be able to get this right. X-ray A and X-ray B. X-ray A and X-ray B. Yes. What does X-ray A show? You want X-ray B? It's easier. We can go to X-ray B. Yeah. Sanket, okay, okay. A is middle lobe consolidation. Somebody says B is parapneumonic effusion. Oh, okay. Okay, where is this pneumonia? Let's get this straight. B is the easier one. Let's go for B. B, where is the pneumonia? Where is the pneumonia? It's a middle lobe or a lower lobe? Middle, isn't it? So your diaphragm is seen, heart border is not seen, middle lobe. So we got that right. Okay, there may be a small effusion here. We are not very sure. We leave that alone, but it's a nice consolidation. Can you make out? There's a nice line there. So that's not an effusion, right? Okay, fine. Look at this one. This one is a little difficult. Okay, you got a homogeneous opacity. There's a hint of one breakdown here, correct? So this looks like the lung abscess forming inside a consolidation. There's a small cavity surrounding consolidation. Maybe there is a consolidation with the lung abscess forming within it. Okay, it's not silhouetting the lower part of the heart border, neither is it sitting on the diaphragm. So if at all, this is where you will get into trouble, because all the three lobes can come here. One is that you can get the upper lobe also can come, 1, 2, 3, this rib can come here. So it can be something like a upper lobe segment except the apical, or it can be the apical segment of the lower lobe can come, and to some extent the middle lobe can come. Okay, but this looks like probably it, and again it is not really silhouetting the ascending aorta, so the plane is not anterior, it's probably posterior. So that's why I would call it as apical segment of the lower lobe. Okay, but you can make out that there's a small hint of a cavity here in this area. Okay, so let's go to the next one. That one. Yes, that one. Hydropneumo. Hydropneumo without a single shift of the trachea or mediastinum. Dead center. Trachea is right in the middle, and the heart is also sitting right in the middle. Okay, not at all shifted, and we are calling it a hydropneumo. So again, of course, it's not very clear. I don't know whether you can see my X-ray well, but you can see the bronchovascular markings here, isn't it? There are bronchovascular markings here. So remember, before you call something as a hydropneumo and such a big one there, okay, you look at this trachea totally central. Unless you have a fixed mediastinum or something happened to you, I mean, you can't really put the trachea there. And the heart also far away from the left, rib cage. So I don't think it shifted at all. So then you look at this shadow, okay, and you got your bronchovascular markings here. So you can't call it a pneumo. It's probably a consolidation, okay, involving the mid lobe, and probably there is an effusion or something. That's why the diaphragm is also not seen. So you can neither see the right heart border, nor you can see the diaphragm. It may be an effusion, but then it has to be a strange effusion. It doesn't really have an Ellis curve. It's nicely cut off there. So that's why you would vote more for a consolidation. You're not seeing the curve up going there. It's a flat line there. So that's why you would probably vote for a consolidation, the total lack of shift of anything. Okay, right. So let's go on to the next one. Yes. Yes. One. Ah, right tracheal shift. Where? Pneumomediastinum, hyperexpanded lungs. Okay, right phrenic nerve palsy, pneumomediastinum, right phrenic nerve palsy, large pneumo. Where? Which side is the pneumo? If you want to call it a pneumo, where is it? Okay, right. That's a right pneumo. Fine. So where is it a big pneumo? Huge one? Then why is your heart not shifted? Isn't it? The heart is not very much shifted. No pneumo. Okay, right. There is a pneumo, right? Look at that. That's a pneumo. That's a pneumothorax, okay? Beyond this, there is no bronchovascular markings, okay? This whole area, there is no bronchovascular marking. There's one here, and then this is the edge of the collapsed lung. That's what I keep trying to tell you, that when you call something as pneumo, you must look for the edge of the collapsed lung, okay? It's not very small either, okay? It's about 10-20% is there. So you can see that this is the edge of the collapsed lung. I'm just tracing it out for you. That. Okay. So beyond this, no bronchovascular markings at all. Up to this, nice bronchovascular markings. Trachea is not very shifted. It's not a big pneumothorax, but it is there. It's a nice pneumothorax here. And what do you think is the etiology? What do you think is the etiology looking at this X-ray? COPD? COPD. Don't call it COPD. Call it emphysema, right? Can be chronic bronchitis also. So there is an emphysema, okay? And you can see the diaphragm is nice, the contour is lost. Okay, it's flattened out diaphragm. And you can see so many rib spaces. They're all widened, even on the normal side. I'm not showing the pneumo side. So that's why it must be a emphysema with a rupture causing a pneumothorax. Okay. So before you rule out, always look at the edge of the collapsed lung. Right? Okay. There's no pleural effusion anywhere. I can't see that. Okay. Right, fine. Let's look at this one. Yes. What's the diagnosis in this? Okay. Somebody is calling it bulla, multiple bulla. Okay. Right. Okay, fine. Okay. This you all made out. So this is the bulla here. This is the bulla here. The total absence of bronchovascular markings inside that. And you can see the edge of the bulla, which is actually compressing on the next part of the lung here also. So you can see multiple bullae here. Okay, 3, 4 are there. And they're all compressing on the adjacent lung. Okay. So this patient definitely has multiple bullae. This is not a pneumothorax. This is not an emphysema, okay, because you're seeing that round thing here. This is round thing here. Here also very thin, nice, thin-walled bullae are seen all over. So this week, I think most of you got it right. Very good. Let's move on. Okay, so I just want to show you one more pneumothorax, which you would have missed if I had not put this line here. This is the edge of the pneumothorax. Can you see that? That's the edge of the pneumothorax. Okay, the edge of the collapsed lung. This is the pneumothorax, that part. So you can see this is the pleural edge and that is the pneumothorax. So always look for it. So when you have a small pneumothorax and you're not really able to see, so what modification in the chest X-ray would you like to do? What would you ask the radiologist to, the radiographer to do for you? What do you do? Okay, you ask for an X-ray in expiration, isn't it? Very few times in clinical medicine do we ask for an X-ray in expiration. Okay, one is to look for a small pneumo, because when you expire, this lung will come shrink further, and you can see the pneumothorax better. Okay. Also, you ask for an X-ray in expiration when you have a subpulmonic effusion and you want to push it into the pleural cavity. Then also you can ask for a X-ray in expiration. The third condition we would ask for an X-ray in expiration is an obstructive emphysema. You got a bronchogenic carcinoma, whatever, some this thing inside the bronchus, which is obstructing and causing a local emphysema. Okay, an obstructive emphysema beyond the blocked bronchus. There you want to see, then you can do an X-ray in inspiration and expiration. When you do the expiration, every other part of the lung will empty itself out. But this part, which is obstructed by the bronchial lesion, will not empty itself. So that will stand out as a black area. So there are three conditions in medicine where we can ask for an X-ray and expiration. One is a small pneumothorax, one is a subpulmonic effusion, and the third is a local obstructive emphysema. Right, fine. So let's go on to the next one. Okay, what is that now? What does this X-ray show? Lower lobe pneumonia. Okay, you're all calling this pneumonia. Okay. Yeah, likely pneumonia. Mass, not a mass. Anything else is there? Apart from the pneumonia that you're calling, anything else is there? Okay, right. Somebody got it, isn't it? There's a pneumomediastinum. Can you make out that? There's a pneumomediastinum nicely there. Okay. So you can see the pneumomediastinum there. Usually occurs in the context when you have a tracheostomy or you have, some pneumothorax, something like that. Or you can get a spontaneous. We even, I think, published a case of spontaneous pneumomediastinum in a person with an asthma. Okay. So it can come. So that, okay, there may be some shadows here which are looking like a pneumonitis, but there's a nice pneumomediastinum on both sides, right? Okay, right. Let's go on. Next one. That one. That's your favorite, isn't it? That's your favorite. Okay, fine. So it's showing a nice big, no-nonsense hydropneumothorax with the shift of the trachea, with the shift of the heart, everything going the other side, the nice big this thing. And that's what I call a straight line. Okay, fine. So let's not imagine pneumothorax being above pleural effusion unless you get that. It's as if somebody's drawn it with a ruler, right? So that's the kind of line you should get if you want to call it a hydropneumothorax. Okay, it's going right through like that. Huge shift of the trachea. Mediastinum is also shifted. Very clear. Upper part is blackish and the lower part is white. Okay, fine. Right. Let's go to the next one. Yeah, what is that now? This is a lateral. This is a PA. So what's that now? Yes. Anyone? Multiple cavities on the left side. And air fluid levels are there. Okay. Okay. So air fluid levels means what? You can see the lateral is going right up there. Lung abscess. Okay. Somebody's calling it a lung abscess. Okay. Now, do you all agree that there are air fluid levels? Okay. This is air. This is fluid. One straight line, one straight line. At least two straight lines you can make out of it. Of course, it's rotated film. All that is right. Okay, fine. And there's some amount of some bronchovascular markings, some flattened diaphragm on the other side. Let's not look at those things. And if you look here, that's your fluid level. There's one more thing there. Okay, fine. Now, always this confusion will come. Is it a large cavity with a lung abscess? You got a straight line there. It's large cavity with the fluid, or it's a hydropneumothorax or a pneumothorax or whatever it is. Okay. Now, one thing you must remember is a lung abscess will again respect lobar boundaries. You can't get a lung abscess going upper lobe and lower lobe, right? It's going to form in one lobe, right? But if you find that in your clinical findings, you got findings that go through the chest, anterior, lateral, and posterior, then you would call it a hydropneumothorax rather than an abscess. Okay. So similarly, when you look at this, you find that this is really going through like that. Okay. This is probably the lateral part, and it's probably showing one fluid level here and one fluid level here. And they all don't seem to be in any particular lower passage. Okay. So that's why the look of it, I would call it multiple air fluid levels. It's a hydropneumothorax with loculations. Many times when you have an empyema, you tend to develop, additions like that, and then they will all loculate like that. And so you can have, multiple these things. To call it a lung abscess, it doesn't look like a real proper cavity like. It looks like vague, the shadow is vague. There's no round here. There's nothing like that. It's all looking vague shadows. So I would probably put it down as an empyema or a pneumothorax with multiple loculations. The only funny thing is, where's the heart, isn't it? The heart seems to be pushed to the same side, okay? I can't see the heart. The spine is totally exposed. Of course, totally rotated film can't really make out where it is. But even then, it's not gone to the other side. So it's a fibrosed lung. If you look at the rib shadows, look at the rib shadows, the widening here, can you make out? And look at your rib shadows here. Obviously, some amount of fibrosis has happened. Look at the crowding of the ribs here. Can you see the crowding of the ribs here? And you can see the width of the ribs here, correct? So there is a good amount of fibrosis that has happened. Now, all this makes you think that it is not just a lung abscess. It's probably a pneumothorax with some pleural fibrosis. That's why you're getting this amount of crunching there. Can you make out? The size of this lung is half the size of the right lung. You make that out. So this is the lung which is really complete, and you can see the complete crowding of the ribs here. All this points to a good amount of fibrosis, and generally pleural fibrosis is much more massive than a parenchymal fibrosis. Putting all these things together, that's why I would probably call it an empyema or a pneumothorax with multiple locules with a compensatory emphysema on the other side, flattening out the diaphragm and some bronchovascular markings being there. We don't know what that is. Okay, fine. Got that? Right. Okay, let's go on to the next one. Okay, what is that? What is that? Pleural-based lesion. Okay. Okay, somebody asked, can we differentiate pleural and parenchymal fibrosis? Parenchymal fibrosis will be in the parenchyma. Pleural will be, more towards the pleural side. Okay, that's the best way. And much more pleural fibrosis, much more fibrosis in a pleural fibrosis. Okay, somebody again called it an pneumomediastinum. No, we are imagining a lot of things, right? Okay, one thing I agree, it's a pleural-based lesion. It could be a loculated pleural effusion, correct? Because the density looks like that of the heart. It is fluid. It is siloting the diaphragm. It is based on the pleural surface, on the lateral surface, and it's just got, no particular shape or size. And so that may be a loculated pleural effusion, unlikely to shift the trachea or the mediastinum. So it's just sitting there. Okay, so that would be your best bet for this X-ray. Let's go on to the next one. Okay, simple. What is that? Very simple. Okay, right pneumothorax. No prize for saying that. Okay, what I want to show you is that is the edge of the collapsed lung. Can you make out? When the lung collapses, it goes posterior medially, okay, towards the hilum, posterior medially, and it forms one thing like that. Sometimes this lung will collapse in 2, 3, round things also, okay, because it's not collapsing as one. In this patient, you got a huge pneumothorax. It's a really big one. Okay, there's a shift of the trachea, the shift of the mediastinum. Okay, the heart has come off the spine like that, and that is the edge of the collapsed lung. So this is a big one. And this is where you should look. There must be an edge. Before you call anything as a pneumothorax, please look for an edge of the collapsed lung. And remember, this is not an obstructive collapse. This is a compression collapse, isn't it? An obstructive collapse is when you have something inside the bronchus, which is causing the lung to collapse. This is not anything inside the bronchus. It's from outside. It's a compressive collapse, either by a pleural effusion or a pneumothorax, and that is the edge of the collapsed lung. So this collapse is not your obstructive collapse. It's a compressive collapse by the presence of the pneumothorax. The total absence of bronchovascular markings is very, very clear. The normal bronchovascular markings. This is a pneumothorax having complete absence of that and looking wider, more lucent. All features of a pneumothorax are very, very clearly seen. The very typical X-ray. So let's go to the next one. Okay. Now let's go bilateral. Sanket, I think I will have to stop in about 15 minutes.
Sure, ma'am.
I don't know. I
Yeah.
don't think I can finish even half of this thing, but I think if I go faster than this, it will
No,
be.
ma'am, this is right,
This
right.
is fine. This is fine.
That's
Okay.
fast.
So
We'll
let's
do it
finish
in next
whatever
class.
we can. There will
Sure.
be a part 2 or a part 3 or whatever.
Yeah,
Okay.
sure, ma'am.
Right. Okay, we are going bilateral now. Okay, I gave you a clue also. So what is this? What is this? Yes, both sides of the lung, something is wrong, right? Uh-huh. Okay, somebody called it left pneumothorax. Left pneumothorax. Left hydropneumothorax. Okay, that's better because we got a line here. Better we call it a hydropneumothorax. Okay, because pneumothorax never has a line. So there is a line here. It's a hydropneumothorax. Okay, whatever it may be. And this side, what happened? What happened to the other side? What does that look like to you? What disease does it look like to you? Okay, non-homogeneous opacity occupying the right upper and middle zones. Okay. Okay. Looks like ILD. It's a predilection to the upper lobe, isn't it? So that's why you should probably think of a tuberculosis. Okay. It's a bilateral condition here, and you got multiple small cavities are there. Some amount of fibrosis is there. Could be an ILD, but because you got, this kind of a Apollo predilection, you'd probably think it's a tuberculosis, which you have to rule out. And of course, tuberculosis presenting like this is rare. There must have been a cavity here which would have ruptured. This would have caught the hydropneumothorax on this side, and the tuberculosis parenchymal remains here. No, this doesn't look like cannonball mets. We will show you cannonball mets when it comes. Okay. What is that? What is this? Okay, correct. That's right. It's a left destroyed lung, but you never looked at the right side. The right side is also showing something, isn't it? There may be a consolidation. We don't know what this is, what the shadow is, we don't know. But the destroyed lung part is correct. Okay. There's a left destroyed lung. This is what we call as a destroyed lung. Again, no. Okay. Right, fine. Probably due to tuberculosis, could be old healed also. The trachea is completely on this side. Heart has moved away from the spine and sitting here. This is probably the heart. Don't go and call this a consolidation. There's no consolidation here. Probably this is the heart. And then you got a lot of fibrosis, lot of cavities sitting here. And like what we told, the size of the left lung is about, 40% of the right lung. The right lung has gone in for a compensatory emphysema with the pushing down of the diaphragm and widening of the rib spaces. And there is one more thing there. We don't know what it is. And definitely there is good amount of fibrosis. Somebody asked me, how do you differentiate parenchymal from pleural fibrosis? You can't really. But this kind of, for example, a destroyed lung like this fibrosis can be quite bad. Okay. So that's why this is all looking like that. But if it's a pleural based thing, then you would have, pleural effusion or pleural thickening could be there. But here, because of the presence of cavitation and this thing, you are probably calling it a parenchymal fibrosis. Okay. So this is a left, this is what we call as a left or a right destroyed lung. This is called a destroyed lung. That's a terminology that is used. Yes. Again, a simple X-ray. Okay. Okay. How do you know it's TB? What are all the differentials for a miliary? What are the differentials for a miliary? Yeah. What are the differentials? Only tuberculosis. There's so many, no? Go on. Somebody is calling it silicosis. Okay. Pulmonary alveolar microlithiasis. Okay. What happened to tropical pulmonary eosinophilia? Isn't it? Histoplasmosis. Okay. There's so many conditions which can present with miliary mottling, right? Lymphangitis carcinomatosis. So many are there. Okay. So there's no mitral stenosis here, please. Okay. This is a miliary mottling, and whatever you read as a differentials for miliary mottling should be thought of. And of course, the commonest is miliary tuberculosis. Let's stick on to that. Miliary tuberculosis is the commonest. You would do an eosinophil count. You would look for other conditions, which have caused miliary mottling, like what you said. Some of them you have already mentioned. You should look for that. But this is very typical miliary mottling. Small shadows are there. What is that? What is that? Somebody call it cannonball Mets. Cannonball Mets. Okay. Could be. Okay. It's bilateral, non-homogeneous opacity scattered throughout the lung in both upper, middle, and lower zone. Not really looking round like that for us to call it cannonball, but could be. Okay. Could be. It could be anything here. Okay. It could be a bilateral pneumonia also. Okay. ARDS is a syndrome. So this person, whether he has ARDS or not, I don't know. We'll have to go whether he is hypoxic or not. Okay, fine. So we have to apply the Berlin criteria for that. This is definitely not a pulmonary edema because you don't have the crowding of these shadows close to the heart. It's not a bad swing. It's scattered all over. So it's a bilateral extensive pneumonia. Could be, you could call it aspiration. You could call it cannonball, but there is a tendency for everything to look round, but we are not very sure. Okay, I wouldn't bet on it. I would probably call it bilateral inhomogeneous opacities and then take it from there based on the patient. That. No, that was not pulmonary edema. Okay, go on. Somebody is calling this sarcoid. What did you make out? Yeah. How do you describe this? How did you describe this X-ray? Okay, somebody called it emphysema, ILD. It's not emphysema, right? Emphysema, you don't have your tubular heart, flattened diaphragm, those things, wide end space, and nothing is there, right? It's a bilateral. Okay, somebody is calling it perihilar adenopathy. I don't see much. Okay. It's a bilateral, non-homogeneous opacities. But please don't call it miliary. That's all I want you to understand. Miliary is what I showed you. Okay. Small. These are bigger. Okay. And there is some amount of, see, there is one minor fissure thing here. There's a thickening here. And these look like, reticular nodular shadowing. They are not looking miliary. So it's probably some form of ILD is your best bet. Okay. You're seeing some traction bronchiectasis here. Lower down, you're seeing round shadows also. Isn't it? So it's a reticular nodular shadowing with bilateral extensive involvement of the lung and probably some amount of traction. It's not a massive fibrosis. It's not a massive, it's not white like that. Okay. It's like some form of ILD, which is in the fibrotic phase. Okay. It's not acute. What is that? That's probably simple. That's probably simple. That's a pulmonary edema. Correct. That's a pulmonary edema. See, you get your bad swing appearance close to this thing. It's in the, towards the heart. The peripheries are not very involved. Upper part, lower part, not very involved. And you got a pulmonary edema there. It's an inhomogeneous opacities on both sides of the heart with peripheral sparing. Correct. Okay. Go on to that. What is that? Yes. Yes. Go on. Okay, right. So you got bilateral, correct. It's a bilateral reticular nodular shadowing, okay? And not pulmonary edema. Pulmonary edema is what I showed you. It will not be like this. It will be hazy. See the haziness here? This is pulmonary edema, okay? It's not hazy, okay? It's got nice, the fibros is kind of white things are there. It's not hazy like the fluid here. This fluid will clear with your diuretic. You understand? This is not that. This is not pulmonary edema. Okay, fine. So reticular nodular shadowing, okay, on both sides of the lung, correct, correct. And somebody called this a pneumothorax, which is also right. Okay, which is also right. There's a small pneumothorax, and there is one more pneumothorax on this side. Okay, it's a bilateral pneumothorax. You can see the edge here, not touching that. Why is this reticular nodular shadowing not touching the edge of the rib cage? So there is one more pneumothorax here. So it's a bilateral reticular nodular shadowing with bilateral small pneumothorax. Could be an ILD, something like that, which ruptured, and then you got a pneumothorax on either side. Okay, fine, right. Okay, some more bilateral. Oh, something I didn't. Yeah, yes, yeah. So there are two X-rays here. Two are there, this one and this one. Are they the same or are they different? Are they same or are they different? Somebody called it Miliary nodules. A or B? Somebody called it hilar adenopathy. There is no adenopathy here. Yeah. B is nodules. What is this? What is A? What is A? To be commented on CT. Yeah. What is A? Miliary, correct. A is miliary, okay? Because you see the sandstorm appearance. This is what you call as a sandstorm appearance, like scattered, it's like sand, okay? So it's so small, and if you, the miliary is probably the easiest to miss on an X-ray. If you over penetrate, if your exposure is bad and everything becomes black again, then you will completely miss your miliary. So that's why, yeah, if you have a problem with any of this, you would ask the radiographer to take the X-ray again. So that's a miliary. That's how it looks, like some kind of gritty thing, like a sandstorm appearance. Whereas this is not miliary. By no way is miliary. This is a reticular nodular shadowing. This is more fibrotic. There are areas where you get some cavity kind of thing. So that's why I put two X-rays in the same slide for you to understand that this is miliary, whereas this is not miliary. Okay. So these are two different X-rays from completely different diseases. And that's your miliary. That's how a miliary looks when you take the X-ray close by. So that's the size of the millet seed. That's how it looks. Okay. Sandstorm appearance. Okay. Just going through like that. Okay. And please don't think these are rib erosions. They're not rib erosions. Okay. They're just the miliary sitting on those ribs. Okay. You're seeing them. That's all. Okay. What is that? What is that now? See, the point is when you see, okay, you're calling it pulmonary edema. Could be, but again, it's going far away. Okay, going far away. It's a bilateral extensive. No, there's no pneumothorax. Probably not a pneumothorax. Okay, right. There's a bilateral non-homogeneous opacities on both sides, which can be anything. Okay, like Probably not pulmonary edema, doesn't look like that, but it could be, some bilateral pneumonia, isn't it? You had COVID, you had H1N1, you had all kinds of pneumonias. You can have an aspiration, you can have any sepsis causing, something like an ARDS, and it is causing patchy lung opacities. All these are possible. All these are possible. And we cannot give a differential on this without understanding the clinical picture. But it's a bilateral pneumonia is probably your best bet. What is that? What is this one? Okay, that's your cannonballs. Can you make out the difference? If you had it like this, then you would call it a cannonball. You would never have any doubts on this. These round things which come, this is a mets from whatever, kidney, stomach, wherever, the thyroid, all these things could have caused the cannonball mets. What is that? Yes. What is this showing? A simple X-ray. Okay, cavity where we're calling it a bulla. This one. Okay. What else is there? Left apical bulla. What about the rest? What about all this? Who's going to answer for all this? Right? Pneumonia. Okay. Where is the pneumonia now? Bilateral heterogeneous lesions consolidation. Doesn't really look like a consolidation. A lot of fibrosis going on. You can make out some strand kind of things, isn't it? So pneumonia will not be so haphazard, right? So there is probably a bulla here. It could be a cavity also. There is an extensive fibrosis here also. The whole picture, if you ask me, it looks like bilateral extensive tuberculosis. That's where I put it in. Because of the presence of so much of fibrosis this side and this side, that's where we would think. Please understand that all these x-rays, though we are interpreting in the class just for fun, you must remember that always they must be interpreted with the patient. So if the patient has some history of tuberculosis in the past or is having tuberculosis now, we just close our eyes and say, this is tuberculosis and nothing else. If the patient doesn't have, even then, even if you call this a bulla, these are not explained by emphysema. There are fibrosis. There is cavitation. So fibrosis and cavitation together would be old pulmonary tuberculosis, even if it is there. Okay, fine. So remember that you must think of the presence of these things also in addition to whatever this was. Yes. What is that now? Lung abscess, cavity. Okay. Okay. So there is one cavity here on the left side. Okay. There seems to be some amount of fluid level. So that's why, remember, a tuberculous cavity hardly has any fluid level. It's always drains because most of the times it's in the upper lobe. Whereas lung abscess will have a nice thing. But the point is, there's no straight line like that. Okay. So when you see a lesion like that, you have to go with the history. Okay. So what else could be the differential of this? Apart from having a lung abscess, what else could it be? No, that's not an aspergilloma. No, that's not an aspergilloma. What else could it be? Vaginous. Okay. Cyst. No, it's too thick-walled, isn't it? What else could it be? Cavitating malignancy. That's what you'll always be worried about, okay? It could be a cavitating malignancy, which could be the differential for a lung abscess because it's a thick-walled thing there. It's a little ragged. It's not really a round thing. So that's why, given the background, you have to go with the history of the patient. But remember that this could be anything. Could be a lung abscess, could be even tuberculosis, okay? But it's not a straightforward line like that. This could be a tuberculosis. Of course, it's not upper lobe. It could be lower lobe. It could be apical segment of the lower lobe. We don't know, right? And usually for a lung abscess, this is not the site, right? If somebody aspirates in the sitting position, they would probably get a lung abscess or an aspiration down to the lower lobe segments, okay? Or if they aspirated in the lying position, it would go to the posterior segment of the upper lobe, okay? So again, and of course, the lower lobes, the posterior segments, but this is somewhere in the middle here. Looks like the apical segment of the lower lobe. That's where this would probably come. We don't know. So that's why the odd position, you have to think that you must keep one more differential in mind. Probably there could be a malignancy. Okay. That's a little more straightforward, correct? That's your lung abscess. That's what you're all talking about, right? That's a lung abscess, nice fluid level. You won't call it tuberculosis, correct? You would call it a lung abscess. Okay, fine. So this is a nice upper lobe lung abscess, beautifully seen. Okay, and this you can go with your usual organisms. Okay, Klebsiella, staph, Streptococcus sometimes, or anaerobic organisms. You can go on like that. Okay, fine. Okay, look at that. What does that show? Okay, we'll go through with this. This is definitely a consolidation here. Okay, and there is an attempted cavitation here. The diaphragm is seen, the heart is seen. They're not touching either of them. So it could be again one of the apical segment of the lower lobe, one of those segments with a consolidation, with a cavitation probably inside. Okay, so we'll just cavitatory pneumonia as probably the best possibility. What does this show? Okay. What does this show? Simple X-ray, multiple cavities, isn't it? Bronchiectasis, correct. Okay, cystic bronchiectasis, multiple cavities. They're all round here, everywhere. So this patient must be having squeaky, leathery crepitations here. And that's what you would think of because it's basal. You're not going to think of post-tubercular bronchiectasis. Probably it's your usual bilateral basal bronchiectasis. Okay, fine. So let's go on to the next one. Okay, what is that? We are nearing the end of the respiratory. Once I finish this, I'm going to stop. So what is that? Thin-walled cavity. Cavity or cavities? There are multiple, isn't it? There's one here, there's one here, there's one here. Okay, there's an attempt here. God knows what this is, isn't it? Okay, so there are multiple and these could be, okay, could be a hydrated or single one. What about multiple ones? If you have multiple cavities, what would you think of? You'd probably think of vaginas, okay. GPA, right. No, these are not looking like GPA and all. No, they'll be nice and solid like that. Okay, something like that would be better off to call as a GPA rather than this. Okay. Multiple cavities like that, if you have, and your patient is sick, then you'll probably think of a pneumotocele, which could be happening in a context of a staph pneumonia. Okay. There are multiple lung abscesses. That's what will come to your mind. Right. Okay, fine. Let's look at that. That's a typical transformation of, what is this? The right upper lobe consolidation, beautifully lined by the minor fissure, trachea in the middle, homogeneous opacity, which can transform into a cavity. So when you're asked for the complications of a pneumonia, that's what you say, isn't it? The consolidation can go on to a lung abscess, can spread to the pleura, can become an empyema, pneumonic effusion, and then it will go this side, pericarditis, myocarditis this side, and then it can spread outside and then go wherever it wants and cause a septic shock, right? So this is a consolidation which is becoming a lung abscess. Okay. Right. Yes. Yes. What are these? Okay. Fibrosis, cavitation, okay, and multiple small cavities are there, etc. Okay. So they're all looking like multiple small cavities, bronchiectasis, need not be lung abscess. They may be just cystic bronchiectasis which are sitting there. Okay. So these are all the causes of cavities in the lung. Okay, you can get this list from anywhere. Like we said, Staph aureus, Klebsiella, Legionella, Pseudomonas, anaerobes, nocardia, infective endocarditis, okay, mycobacterium, tuberculosis, atypical, and then the whole list of fungal infections, and then parasitic infections. And there you see the differential that comes in, which could be a bronchogenic carcinoma or a metastatic thing, or sometimes even a lymphoma. And there you said about the GPA, the rheumatoid, thromboembolic emboli can be there. And then congenital cyst pulmonary sequestration, which is a rare condition. Okay. And of course, pneumoconiosis, then PLH and all this stuff. These are rarer causes. Okay. Bronchiectasis, like what we said. So that's a whole list of cavities in the lung that you can think of. I think we'll finish in about 5 minutes. Okay. So the last few x-rays, run through it. Again, this is a destroyed lung. Okay. Don't call it a collapse. It's a destroyed lung. Okay. Showing a lot of fibrosis. The trachea shifted to this side. There are some cavities here. There is a compensatory emphysema on the other side. Okay. So probably is more of a destroyed lung than anything else. Remember that when you differentiate a fibrosis from a collapse, fibrosis is something that takes time to happen. Collapse can be acute or chronic. If it is acute, it will only shift the trachea. It cannot cause structural changes. You cannot get rib fibrosis, chest wall rib crowding in 1 week. It will take months. Okay, so when you have a lot of rib crowding and the whole chest looks smaller, it's a chronic process. So it's a chronic process. More often is a fibrosis than a collapse. Okay. Very simple X-ray, but something that you should always know. What is that now? What is this X-ray? Anybody? Right upper lobe, reticular, nodular opacity. Tuberculosis, correct. Okay, I'm sorry. I think I jumped a slide. Okay, that's a tuberculosis. Okay, and these are what you call as soft shadows, right? And they are likely to be active tuberculosis. Okay, though we say there is fibrosis, I'm not denying that. But once you get this small, opacities there, which are looking soft to you, the tuberculosis is likely to be active. Remember that once you treat the tuberculosis, the fibrosis will not completely come back to normal. The fibrosis is going to remain. The cavities which are big are not going to close completely. They may remain. So fibrosis and cavitation can be there in old tuberculosis or current tuberculosis. Cavity in an untreated patient is a sign of activity. Cavity in a treated patient need not be activity. So remember that if you have soft shadows, what we call as infiltrates, then it's likely to be active tuberculosis. And cavity, if it is untreated patient, likely to be active tuberculosis. But fibrosis and cavitation, patient doesn't have any symptoms, could be old tuberculosis. So go clinical. Go with your fever, weight loss, loss of appetite, hemoptysis, pleural pain. The usual symptoms of active tuberculosis must be there for you to think of tuberculosis. Just don't go with the X-ray. But in an X-ray, somebody asks to pin you down, then you say infiltrative tuberculosis, soft shadows are likely to be active, and cavity in an untreated patient is a sign of activity. Now, just concluding, here we have some, this thing, I think this X-ray has been, similar one was shown to you. There is a bullae here and multiple reticular nodular shadowing and all. But like I said, looks like tuberculosis. That's an ICU X-ray. Patient is intubated. You can see the intubation thing here. And this is multiple small consolidations everywhere. This is what would this patient probably would be in ARDS. But ARDS is not a disease. It's a syndrome. It could be aspiration. It could be anything. It could be, a sepsis, septic shock, and with an ARDS or pneumonia. All these are possible. Okay. Now, the last few X-rays, what is that now? What is this one? Yeah? Dextrocardia, correct. It's a dextrocardia, okay? Not a right diaphragm palsy. Please remember, this is a dextrocardia. This thing has come here, okay? Look for your stomach shadow. Probably it is on this side. If it is so, it's a situs inversus. And of course, why is this diaphragm high? That we don't know. We'll have to think, okay? But we can't call it straight away. Just that, it's a diaphragmatic palsy. It's probably a dextrocardia. No, there is no hydroneumo. Right. Okay. Right. Okay. That one. mass, okay, okay, could be a mass. If it's a mass, then you have to definitely consider it as, you have to think of a differential of a solitary pulmonary nodule. And you have to consider all the differentials for a solitary pulmonary nodule. Okay, we'll go on to the next one. So those are your differentials for a solitary pulmonary nodule, which can be malignant or benign. The malignant is your bronchogenic carcinoma, lymphoma, METs, single MET, okay? And then you got the hamartoma, teratoma, hemangioma, chondroma. These are all your benign. And infections like grandoma, like we said, even a GPA can cause a single one, a tuberculosis can cause spherical pneumonias are known to occur, lung abscess, parasitic disease. And you have vaginous, sarcoid, rheumatoid, pulmonary lymph nodes, arteriovenous malformations, and of course, pulmonary sequestration, right? The important thing when you have a patient, when you have a this thing like this, if you are given an X-ray like this and asked whether it is benign or malignant, always go with the patient. If the patient is older, is a smoker, there's no way this is going to be benign. If you see calcification, then likely to be benign. Okay, and then the smoothness of the border, the benign one is more smooth. The this thing one is not. If it's associated with the lymph node here, there's a bulge here, there's a mediastinal node, then you would not call it benign at all. So you're going with the context of the clinical picture and also the differences, which is what is showed here. Smooth is benign, irregular is this thing, calcification is benign, doubling time is always much longer for a benign, whereas it's short for a malignancy. And the size, the bigger the nodule, don't call it benign, always call it malignant. More than 1 centimeter is probably malignant. Okay. Sanket, should I stop?
Yeah, ma'am. If we are changing system, I think that's fine. Or we can do as a part two also.
I'm not
I'm
saying,
fine.
I have
That's-
just, I think 5 more slides to finish respiratory.
Yeah, I think
Shall I
then
finish it
we
off?
do student. I think student will say yes only. This is very interesting class. So
Okay,
if that
okay,
is fine, we will continue, ma'am.
okay, okay. Fine. And then I'll finish it off. This is the last part because
Sure.
it seems to be going on and on. That's why I said,
Yeah.
not students around, I can't even see anyway. Right?
The,
Okay. What
the
is this
number is
showing?
yeah. We got yes. So let's start.
Okay. Okay, right. Okay, that's some hardcore fellow. We don't know who he is. Okay, right. Go on. Yeah. Yes. What is this showing? Fibrosis. Come on, I say. Where is the fibrosis? Like that. Okay. Right? Pneumonia with a collapse. No way. Right? No way that's a pneumonia with a collapse. Why should a pneumonia cause any collapse, isn't it? Okay, you are calling it a consolidation. Something is odd about this consolidation, right? Something is odd. What is that bulge now? Isn't it? That bulge. You have to worry about it, right? Okay. So you got a homogeneous opacity in the right side. Okay. And probably you got a lymph node here. You would think it's a malignancy. Okay. You would think it's a malignancy simply because this thing is not, wedge shaped or nice cut off, nothing like that. It's a segmental consolidation, if at all, but we don't like that bulge. Okay. That bulge is something definitely cannot be ignored, and we have to call it a malignancy. Unless you disprove it, you will never call it anything else. That one? That one. Okay, hilar adenopathy, right? It's a bilateral shadow, unlike this one where I showed you a unilateral shadow. Remember, a unilateral shadow is likely to be bronchogenic carcinoma, whereas a bilateral hilar adenopathy could be more often, what all? More often, somebody said sarcoid. What else? What else could be a bilateral hilar adenopathy? Lymphoma. Never forget a lymphoma, right? Always a lymphoma will take, high on the cards. Okay. You can get it in tuberculosis, but it is rare. But lymphoma will be high on the cards. And of course, every other cause, T-cell leukemia, all those things, any of them can cause a bilateral shadow. But a unilateral shadow is more likely to be a bronchogenic carcinoma. That's why I brought you this X-ray. Okay. Yeah, that one. Oh, sorry, I did something. Yeah. Yeah. Okay, it's probably one of the last few. Yeah. Yes, doctor. That's a pleural plaque, isn't it? One that looks, it's a calcium density. It's a bone density, multiple small calcification. These you could call it as parenchymal, but this is not parenchymal. These kind of, vague shapes and all kinds of shapes that are coming out, they are pleural plaques. They are pleural calcification. Here also you can see pleural calcification there. Okay. So this bilateral extensive pleural calcification could be because of tuberculosis, but these could be, your this thing also. These could be tuberculosis also because of calcified spots there. Okay, so that's different, but these are pleural, right? Yeah. Yes. Okay, this we can finish off. It's a hilar widening, mediastinal widening. Could be anything, isn't it? It's a wide mediastinum. Could be anything. It need not be a lymph node. It can be even a thymoma, can be a teratoma. It can be any mediastinal node coming from anywhere. Okay, it can be an aortic aneurysm also, but it doesn't look like one. So all the structures in the mediastinum can give rise to this. So it's a mediastinal widening, upper mediastinal mass. If this patient, by any chance, is in stridor or has dysphagia or has hoarseness of voice or has, puffed face and, your neck veins are prominent, then it's a malignancy. That's a rule. Once you have a superior mediastinal syndrome with features like that, then it's a malignancy. Now, no more go and call it, tuberculosis. Don't call that all that. They do not infiltrate any of these structures. A malignancy does. So remember that when you have a superior mediastinal syndrome with a mediastinal widening, you have to call it a malignancy. Okay. Okay, that's another mediastinal widening that I'm showing you here. It's a bilateral thing. Again, you have to apply the same rules that you have to think of any of these conditions. Okay, that's another mediastinal widening. Again, big one. Okay, coming on both sides. Could be a lymphoma, could be anything else also. Doesn't look like a bronchogenic carcinoma because it's on both sides. Okay, one more destroyed lung. Okay, because I wanted you to understand tuberculosis in all its manifestations. So it's one more destroyed lung with the trachea completely on this side and all these cavities going on. One more miliary. Okay, just to finish, one more miliary is there, and you can see multiple small cavities also, and some amount of consolidations happening somewhere. But these look like miliary. Again, miliary is not only tuberculosis, there are multiple causes of miliary mottling. One more bronchogenic carcinoma, one more small, probably some amount of lung abscess could be there. That's one single solitary pulmonary nodule that you can see there. Okay. Okay, that should be probably the last. What is that? We'll end with this. What is this? Anybody? Why is nobody answering this? This is a Chilaiditi sign, right? It's a colon, interposition of the colon between the liver and the diaphragm. It's a Chilaiditi sign that you see here. Don't go and call it perforation. You can see the prostrations of the colon there. Okay. I think we'll finish with that, Sanket. You have to stop somewhere. Okay. We'll
Yes.
continue in another class.